Hey everybody, so we're going to continue talking about ABG interpretation. We're going to dissect another type of ABG and talk about why that we label it the way we label it. Just to go back over, we need our pH to be 7.4 to be considered just right, baby bear soup. The range is 7.35 to 7.45 is acceptable. If the ABG is out of that range, we know that it is uncompensated or non-compensated, and we need to make some care planning and execute something to get it back into range before that patient falls out too far. The sooner that we react to an abnormal ABG and correct it, the less invasive that the correction might have to be. So the blood gas needs to be between 7.35 7.45 on pH. 7.4 is perfect. Our PCO2 needs to be 35 to 45. Our PO2 needs to be 80 to 100, and our bicarb 22 to 26 is normal there. Okay? So let's talk about a patient that has a different issue than we've discussed before, and that is a 36-year-old patient who is a known a patient with diabetic issues. They have diabetes mellitus, and they come into the emergency room, and they are tachypnic and hyperpnic, which means they are breathing extra breaths per minute, and they're larger than they normally are. So our blood gas for this patient is 7.27. So we know that's acidotic. Our PCO2 is 36, so it's within normal range. Our PO2 is 89, so that's good. That's within normal range. Anything 80 to 100 we're going to be okay with. Our bicarb is 16. So we know that that is low and is considered acidotic. So our pH and our bicarb are both acidotic. They're both going in the same direction. They're both lower than normal. So we know that when it is affecting the bicarb and the pH, it's a metabolic issue. And when it's decreased, the pH is decreased below normal, that's an acidosis. So our diagnosis for this patient is non-compensated because it's out of range.
Save 2 minutes via Florence.
Metabolic.
This route requires
Metabolic acidosis because of the diabetic ketoacidosis. And our treatment is we're going to have to give the patient some sodium bicarb because it is lower than it should be. Our normal range for that is 22 to 26, and our bicarb is dropped down into the teens. So we need to give sodium bicarb to help give that acidosis a little boost and try to bring it back into range. We're going to need to give them some insulin for the diabetes to pull their blood glucose back into that around 100, hopefully, for the fasting blood glucose, or at least down within a decent range, less than probably 160 or so. It's according to, a few different factors there. So we need to get their diabetes under control, get that hyperinsulinemia or hyperglycemia. There's several different terms that we could use to describe that. We need to get that corrected so that their pH and their bicarb can come back into range and come back to homeostasis. So just remember, if the bicarb and the pH are both low, that is a metabolic acidosis. We need to give the patient bicarb and correct the problem that's causing the pH to be out of range. And in this case, it's diabetes. And we know that we see the breathing pattern Kussmaul's respirations with diabetes, so be familiar with that. Be familiar with what a normal blood glucose is, and that is somewhere around 100. Fasting or less is great. So remember that diabetes and sleep apnea often run together. So they may have some obesity, and they may have an increased waist circumference, increased neck circumference, low energy, very fatigued very easily, fall asleep easily during the day, morning headaches because they've been hypoxic during the night, or their PCO2's been up some because they're hypoventilating. And a lot of times diabetes and sleep apnea run together in the same patients. So, okay, well, thanks for listening. I hope that helped you understand diabetic ketoacidosis and how to recognize and correct a metabolic acidosis in an ABG. Have a great day.